move on to our next speaker, Dr. Jennifer Price, and she's an associate professor of medicine at the Division of Gastroenterology and Hepatology at the University of California, San Francisco School of Medicine. She's also the director of the UCSF Viral Hepatitis Center. The title of her talk is No One Waits, Community-Based Approaches to HCV Elimination in San Francisco. Dr. Price, take it away.
Great, thank you. Thank you so much for inviting me to give this talk. I'm really happy to be here. I wanted to start with providing some context surrounding the work that I will be presenting. So in San Francisco, we estimate over 11,000 people are living with active untreated hepatitis C. And an estimated 90% of these are people who inject drugs, which by contrast, people who inject drugs make up only about 3% of the total population in San Francisco. So in 2016, San Francisco became the first US city to launch a hepatitis C elimination initiative, and we call this End Hep CSF. And End Hep CSF is really a community-owned collective impact initiative, and it's comprised of a real diversity of partners and stakeholders, all with a shared mission to support all San Franciscans living with and at risk for hepatitis C. There are 5 pillars of collective impact models that I've listed here, and you can see on the right how we structure our model with the various working groups. And since its inception, the group has recognized some key barriers to hepatitis C testing and treatment in San Francisco and has worked really hard to successfully execute some solutions to these barriers. In the interest of time, I won't read through all of these, but I just wanted to draw your attention to a couple of them. We've developed a really successful community peer navigation program. And then also, in addition to a lot of advocacy work from other groups, as well as End Hep CSF, successfully advocated for the removal of DAA payer restrictions in the city. So I wanted to provide that background because the work I'm going to be talking about was conducted in the context of many people working very hard to mitigate many of the systems, provider, and patient level barriers to hepatitis C care that we know helps contribute to disparities in the care cascade. So it was in this context that we launched the No One Waits or Now study in 2020. This was a community-based point of diagnosis hepatitis C treatment study. And our primary objective was to establish the feasibility, acceptability, and effectiveness of an on-site Hep C point of diagnosis treatment model, in which we provided 2-week starter packs of sofosbuvir velpatasvir at the time of active Hep C confirmation, and then attempted to obtain the rest of the treatment course through insurance-provided medication. It's important to note that our study site was actually not a clinical site. It was a community-based site. It was the Quaker Meeting House in San Francisco, and I've shown a picture of it here. And the Quaker Meeting House is located by the Civic Center area. And we specifically chose this site because it was close to where our target population tends to congregate and was also close to public transportation. So I'm going to spend a little bit of time walking through the study design. There were basically 2 phases of consent. The first phase was consenting to hepatitis C screening. So we screened with the rapid Hep C antibody. We also did rapid HIV testing at that time, so just the finger stick. If the antibody was reactive, then we proceeded to venipuncture and sent the blood for Hep C RNA and also hepatitis B surface antigen. The participant came back the following week for their RNA disclosure. And if the RNA was positive and they met inclusion criteria for on-site rapid treatment start, they were offered enrollment in the NOW study. If they consented to enrollment, then that same day, we drew pre-treatment labs, and I've listed the pre-treatment labs here. We set up a telehealth clinician encounter, so they had a clinician encounter, and then they started that day sofosbuvir velpatasvir with a 2-week starter pack that was provided by the study. Behind the scenes, then we prescribed the remainder of the treatment course and attempted to get insurance authorized medication. So here is our enrollment. From July of 2020 to October of 2021, we screened 490 people for hepatitis C. Exactly half were anti-Hep C antibody reactive. And among them, 111 were Hep C RNA positive and eligible to enroll in point of diagnosis hepatitis C treatment. Now, of those, 89 returned for their Hep C RNA results disclosure. And of those who returned for their disclosure, 87 elected to enroll in the treatment arm of the study. So I just want to pause here and point out a couple issues. One is that 7% of our participants who were antibody positive were unable to get confirmatory testing because we were unable to draw blood, and we had a very skilled phlebotomist. So the requirement of venipuncture for RNA confirmatory testing is still a major barrier, particularly for our patients who have a history of injection drug use. The other thing I want to point out is that we had 126 people who were RNA positive, and the majority of them were eligible for what we called a modified, simplified hepatitis C treatment algorithm. So essentially, most of the people that we were screening were eligible for simplified treatment. I've listed on this slide the reasons why the other 15 were not eligible. Also want to highlight that we lost 20% of those who were eligible in between visits 1 or 2. So anytime we have a step in the care cascade, there's the opportunity that we can lose people to follow up. But among those who did follow up for the RNA result disclosure, the vast majority, 98%, enrolled in same-day treatment. And the other 2 who declined enrollment, they really declined because they didn't want to participate in a research study, but they were successfully referred to standard of care treatment. So here's our study population. Our median age was 48, 71% were male. I want to highlight here that 61% had slept outside or in a vehicle in the past 12 months, and 43% were currently living outdoors or in a vehicle. Only a small percentage were what we would consider to be stably housed, 97% with an income below the national poverty line, and 80% had reported any injection drug use in the past 3 months. Also want to highlight that 94% were insured at the time of enrollment, which I really think speaks to our excellent safety net healthcare coverage in San Francisco. So as I mentioned, 87 people started treatment, 69 of them, so 79% completed treatment. Among those that completed treatment, 92% had an undetectable Hep C RNA at the end of treatment. And among those, 95% had confirmed SVR12. So there were 3 people who were undetected at end of treatment, who then were detected again at SVR12. And we believe that 2 of those 3 actually had a reinfection during that post-treatment follow-up period. So overall, our intention to treat SVR12 was 67, and our protocol SVR12 was 84. Important to note that we did see a lower SVR12 in people who had experienced homelessness over the past 12 months. Again, showing that homelessness is a major barrier to treatment completion and Hep C treatment success in our patients. There were no adverse events causing premature treatment discontinuation. And importantly, we did not have to make any alterations in our treatment based on those pre-treatment labs that were drawn on the day of their DAA start. So remember, we drew the pre-treatment labs before they took their first pill, but we didn't get the results back until after they had already started treatment. Now, an important component of the feasibility of the study was that we used staff-assisted telemedicine to provide Hep C treatment. We conducted a telemedicine sub-study, and 94% of the respondents thought that receiving clinical care via telemedicine was helpful. And actually, most of them, 81%, were interested in using telemedicine in the future to address another health condition. Another hugely important component of the study was the collaboration with the pharmacy team. So remember, the study was designed to give a 2-week starter pack of sofosbuvir valproatovir, but then we provided the remainder of the treatment course through insurance-provided medication. So how did this work? I put here on this slide all of the different steps from intake to medication dispensation, as well as the team members involved and the approximate amount of time that each step took. So big picture, what you can see here is it required a lot of collaboration. There were a lot of steps, and some of the steps took a lot of time, but a variable amount of time. So for example, the benefits investigation could be as quick as 5 minutes or as long as 7 days. The insurance approval could be one day or 3 days. But we were able to successfully transition to insurance-covered DAAs in 91% of participants during the 12-week course, and 77% of them transitioned after the 2-week starter pack. So that was really our goal, was after they got their starter pack to successfully transition to insurance-provided medication, and we achieved that in 3/4 of the population. But 23% did still require additional study drug to prevent treatment gaps, and 9% remained on the study-provided drug throughout treatment. So I've listed here some of the reasons for delay in transition to insurance-covered DAAs. A few of our participants, they were insured, but their insurance was out of our network, so our clinicians couldn't prescribe at Kaiser or at the VA, for example. And there were a few people who were not insured, so we had to assist them to get insurance. But the most common reason for delay was actually that some of the contracted specialty pharmacies required oral consent with the patient to deliver their medication, and that ended up being a big barrier. So our key lessons was that collaborative teamwork with the pharmacy was needed to meet our goals. And even though we had a highly insured population, there still were insurance-related barriers. And it was particularly difficult for individuals without stable housing and without a phone to receive their medications without insurance. Finally, free medication programs were really essential. So the donated study drugs filled the gaps in treatment, and we also needed copay assistance for some of the participants. Now, one of the big patient-level barriers to completing treatment was actually medication security. So 63% of our surveyed participants reported concerns about safely storing their DAAs, and 1/3 reported missed doses due to medication loss or theft. So this led us to develop with patients medication security strategies, and I've put some examples of these here, as well as the cost. There were low-cost strategies to allow participants to keep their medications on their person. So one example of this, we fashioned necklaces with a bag for each day of the week and put their pills in each bag for each day so they could take their pill, throw out the bag. We modified a fanny pack. We modified a pill box to attach a carabiner so that the participant could loop the pill box on his belt loop. So it was really important to our participants that they could actually hold on to their medications, because if they had it in a bag, it was at risk for being stolen or swept up in a street sweep. So key take-home points from the NOW study were that the point of diagnosis, hepatitis C treatment in the community setting, was acceptable and effective. 98% of those offered actually chose same-day treatment starts. And our SVR12 rates were similar to that in other studies in people who use drugs. And when I was thinking about what the kind of themes were for the success, I came up with a few. One of them is that we really shortened the steps from Hep C treatment, diagnosis to treatment. So kind of decrease the number of chances that we could lose people to follow-up in between their diagnosis to getting started on DAAs. We got this down to a 2-step process. Obviously, we're trying to think about how we can truncate this even further to 1 step. This was community-based. It was not a clinical setting. We met people where they were, and it was important to be close to where our participants lived and congregated and close to public transit. A really important point is the staff-assisted collaboration with the medical and pharmacy team. We thought about how we could utilize the technology we had available to us in a way to address the needs of the population and really maximize the specialty resources, including our specialty pharmacy. And finally, we supported participants on treatment. We had regular check-ins, and then I talked about the safe medication storage devices. So in the last few minutes, just building on these themes, I want to talk about a couple other projects. One is our hepatitis C mobile screening and treatment van, which we call the Deliver Care Van. This actually leverages the clinical infrastructure of our UCSF hepatitis C clinic, and also requires or relies on outside funding, including funding from the San Francisco Department of Public Health, to tailor our services to people who use drugs or who are experiencing homelessness. And our model is similar to the NOW study model, but not quite as truncated. So when we first meet the client, we can perform a rapid antibody test and then conduct venipuncture for confirmatory RNA testing. They'll come back 1 week later for RNA results disclosure. If positive, we do have a portable fiber scan on the van, so we can do a fiber scan. We collect insurance information, as well as all of the clinic consent forms that you would sign, at the doctor's office. We have the client sign that on the van. The following week, we set up a staff-assisted clinician telehealth visit, draw the pre-treatment labs, and after the visit, send our prescription to the pharmacy. And then the following week, the patient gets started on treatment. So from diagnosis to treatment, we can do everything in about 3 weeks. So again, same theme, shortening the steps from diagnosis to treatment. Also, similar theme of meeting people where they are. We ask people after they've been cured how they feel about their Hep C cure. And I included just one quote from one of our patients who was successfully treated, who said, "I was touched that UCSF has come to me because I would not have been able to go to them. It was convenient to have the van outside my methadone clinic. I used to be embarrassed about my Hep C status, but now that I have treated it, I feel confident in being able to follow through with other obstacles." And then we rely very heavily on staff-assisted collaboration with the medical and pharmacy team and try to support patients as best we can on treatment. And just to provide an example of this, I took a screenshot from our outreach summary from one of our sites from last week and de-identified everything. But you can see here, there's a lot of collaboration and a lot of work that goes on behind the scenes to make sure that things move smoothly for our clients. The final example I wanted to give of addressing multiple barriers to hepatitis C care is the multi-site peer-enhanced rapid Hep C test and treat and opioid treatment programs study that is being led by Dr. Shon Vlade-Nulia from Johns Hopkins. And there's actually 2 interventions in the study. The first intervention is randomization to receive Hep C treatment within the opioid treatment program versus a standard of care referral. And the idea here is to really address the systems level and provider level barriers to hepatitis C treatment starts. And then the second intervention is a peer support intervention to try to address the patient level barriers. And this study is still enrolling, so I can't present any results, but in assessing feasibility, we conducted a survey of the clinical leadership at the 5 participating OTP sites across the US and Canada. And the leadership gave very high scores for acceptability to staff of the on-site Hep C treatment model, and also thought that it was appropriate to meeting their clients' needs and priorities. But I think it's important to point out here that they gave lower scores for feasibility. And some of their potential concerns were maintaining the momentum of Hep C treatment in the face of competing priorities, coordinating new tasks to ensure smooth workflow integration, and managing the politics and finances of a new on-site Hep C treatment program. So that kind of leads me to my final slide, lessons learned and recommendations. I think one thing to remember is that simple is not the same thing as easy. And I think the leadership survey at the OTP site is a good example of that. We can really simplify the Hep C treatment regimen, but it doesn't mean that that's simple to execute. It actually can be quite challenging to execute. And our community partners are stretched very thin. It's not necessarily easy also for our patients to take their medications every day and to be able to hold on to their medications. Community engagement and stakeholder input is really, really essential. We need to involve everybody in these programs before we implement them. I think another key take-home point is to leverage the existing expertise, infrastructure, and technology that you have. I know it's cheesy, but I always say to the staff, don't let perfect be the enemy of the good. And I think if we're trying to be perfect, we're never going to get this work done. If we demand perfect adherence to medication, we're not going to be able to treat everybody. And finally, expect the unexpected challenges and adapt to them. So I want to just thank the entire NOW study, including my incredible co-investigators, Dr. Megan Morris and Dr. Annie Lukemeyer, the entire Deliver Caravan staff, the NHEP CSF community, and all of our NOW study and rapid study participants. And thank you for your attention.
Thank you, Dr. Price. That was really very interesting and very inspiring. We have received a few questions. Let me see. One of them was, were the few participants who were apparently reinfected subsequently retreated?
So they were referred, yes, for treatment for outside of the study.
And did you give the study participants cell phones to contact?
We did not give participants cell phones.
Okay. it was really interesting to see that the drugs were being stolen and you had to come up with a device for that. I think that's really fascinating to see some of the challenges that these patients are facing. We will move on to our next speaker and come back to the questions later on.